On this episode of the Ask Mike Reinold Show, we talk about unique pelvis structures, we talk about persistent quad atrophy after surgery, and we talk about stretching people with shoulder impingement. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the Ask Mike Reinold Show. I am up in Boston at Champion PT and Performance. I'm here with Dan Pope, Dave Tilley, Lenny McCrean.
I'm here.
Mike the Scoobs from Northeastern University, here to ask us some questions. Again, guys, thanks so much for having a blast here. The last few episodes, we've really enjoyed your great questions. So keep asking away. Go to MikeReinold.com, click on that podcast link, and ask away, man. We're having fun. We've been doing this for a year now.
Whoa.
Most of us, you guys jumped in a little bit late, but we've been doing it about a year now, and still enjoying it. So hopefully you guys are a little bite of information for you to take throughout the day, maybe. Right?
That makes me uncomfortable.
Yeah, grr.
It makes me very
Scoobs, what do we got for awesome questions today?
First awesome question, Evan from Colorado. I'm currently a strength coach for powerlifters while I'm working on getting into PT school. Have you ever experienced a patient with a structurally tall pelvis experiencing chronic patellar pain due to the fact that the length makes glutes activate harder? If so, any questions?
This is like Pope 10 years ago.
Kind of two questions there too. So let's talk about does a taller pelvis change anything to you?
That's what I'm not really sure. I've never really heard that.
Longer femur.
Well, theoretically, if you have a tall pelvis, you probably have a tall glute and a long femur. But you probably, the glute just, I can't imagine you have a small glute with a tall pelvis.
So what's the problem? What's the change?
Are you too hard? No, it actually makes it difficult to fire the glute.
It makes it difficult to fire the glute.
Yeah. Well,
a longer moment arm to overcome, maybe.
Yeah.
The hip hinge is a broader.
Well, let's ask that question. Does a tall pelvis inhibit glute?
Yeah, so I don't know if the tall pelvis necessarily inhibits it, but that's probably one of the last things I would start thinking about if someone can't fire the glutes properly. Probably look at the front side of the hip, see what's going on in the front of the hip, see if they have any limitations in extension, right? And then maybe see if they can actually fire the glute through a full range of motion. Something like prone leg lift, like you see in the SFMA. See if they're having trouble when they do things like glute bridges. They're actually feeling it in their glute musculature, and those would be the first place I would look. And then once the person can start to fire the glutes properly and like a glute bridge, and they're feeling that muscle work, then I would just progress up through some more specific exercises, more similar to lifting. Maybe some tall kneeling, hip extension, follow that by some pull throughs, and then maybe some deadlifts at the end, and just make sure the athlete is using their glutes. But I apologize if you guys have something to add. That would be the last thing I'd look for.
I would say maybe, like Mike said, if it's a taller person, maybe just a lift to start would be more advantageous. Start them on a little bit of that elevation.
Yeah, a tall, long person. Technically a biomechanical disadvantage, right? Some people are good at certain lifts than others, just based on body type. So, that might be just part of it there. It's just a tall, longer leg person.
Yeah. I'm curious what lift. If you can get back to some point, like what lift and why do you think that's happening?
Nice tweet, Dan. What's your Twitter handle?
Fitness Pain Free.
So at Fitness Pain Free.
Long pelvis.
Send Dan some follow-up questions. I want to get in on this question. Dan's intrigued. He wants to
pique his curiosity.
He wants to answer this. Awesome. So to be continued. Scoobs.
Karen from Wyoming. Hi, Mike. Thanks for all the info you put out. I just listened to your answer to a podcast question about quad atrophy and wanted to ask a follow-up for that. What advice do you have for someone who's had quad atrophy for 3 years and strongly developed avoidance patterns due to an ACL rehab gone bad, stubbornness, and mountain guiding?
I like that. In mountain guiding, like that's your profession or yeah, right. So I'm glad you actually put that part in there, because you were stubborn, bad rehab, whatever you want to call it, and you returned probably back to your activities, which is probably a lot of activities on a weak quad. It's that's.
I'd rather know why you have still a weak quad. Is it that you're lacking extension in the knee that'll contribute to not being able to get the quad back?
Maybe not pushed enough in the advanced rehab stage.
Yeah.
Right,
Not
we're
doing the
pushing
right
enough.
stuff right now.
I mean, you hate to say it, but did you have a femoral nerve block and there's some neuro thing underlying going on that you need to have further assessed? Because if your quad's not coming back 3 years later, I mean, we sometimes have seen that in some ACLs, and I blame PTs because we don't know how to progress people into that phase 4, so to speak. But I would look at those things to make sure you have your motion, make sure nerves are functioning correctly, and then if that's the case, then maybe find a local PT. Maybe you need to do like blood flow restriction stuff. That's opening a whole can of worms. Whether or not that's going to be helpful for you to try to get your quads to hypertrophy. And then you really got to load it again.
Yeah,
you know?
you got to get in the gym.
Yeah.
You know, and that's probably part of it. I mean, it's not weird to have prolonged weakness, and if it's a year out and you have prolonged weakness, which is not uncommon, and you don't address it, then yeah, that becomes 2, 3, 4, 5 years because you still haven't addressed it.
Right.
So, you know, you'll continue to get better, I guess.
I would say a caveat too is I think a lot of PTs are really good at loading bilateral exercises, but don't load up the single leg exercises. It's heavy, so step ups, lunges, you know, single leg squats or box. Like people are usually like jumping to front squats and back squats, like killing it with a goblet squat. But you got to make sure that the asymmetry is, you know, reduced before you start going heavy on a double load exercise.
Yeah.
It's
Like,
personal.
how many patients do you see that actually go through a thorough strength and conditioning program and put the time and effort in that you
Correct.
need to gain the strength
Up
back?
to 70,
Yeah.
80%.
Yeah.
We've had athletes come to us 4 months after surgery. They're still doing 3 sets of 10 of like straight leg raises and stuff like that. It's amazing. So yeah, you know, you gotta. That's like the first month, you know, and then you gotta progress from there. Awesome, Scoops.
Samantha from Georgia. Hi, y'all. Can you please explain your technique
Love
when
it.
stretching a patient with shoulder impingement? I try to stretch posterior via cross body and also stretch the lat, more sagittal. My problem is when a patient complains about a pinch in these movements. How do you go about stretching while avoiding a pinch? I've seen where people distract laterally with bands, but feel like this is more addressing the capsule rather than the muscle.
Right. Who wants to start on that one there?
I would say sometimes you have to reverse engineer the total motion and see what could hang up along the way. I think sometimes we just stretch the motion, not realizing there's like 4 or 5 muscle groups that really have to extend well to get to your end range comfortably. So looking at each one, I kind of do like a test, retest, which I think all of us kind of do, is like when you see a limited, kind of treat one, retest it, treat one, retest it, rather than just keep cranking the end range.
And you're saying treat it via like soft tissue techniques
soft tissue
or something
yeah,
like that?
exactly. Not more stretching, sorry.
Yeah, so if you have impingement with overhead elevation, we'll say, I don't think the first thing I would do is stretch them into overhead elevation. That's a big self-mobility thing on the internet. You just, you know, grab a band, distract your arm, and jam it up. You don't have overhead elevation? Good, jam it up there. That'll get it. That makes no sense, right? So figure out why you don't have that elevation and work on that, and stop stretching them into a pinch. That's the body telling you that you're encroaching, you're impinging the inflamed tissue. You know, figure out the source.
But yeah, exactly. That was it. She said it in her question that people think that they have to put bands to stretch the capsule. Well, maybe you do need to stretch the capsule. If they have impingement, I'm going to guess they're 30, 40, 50 years old. You know, they're in that age group where you start maybe seeing a little more capsular type stuff. So maybe they do have a capsular issue that you need to address. And then the soft tissue, and then the motion may come. So I would look at all that.
You check their passive range, you check their accessory motion of the joint to see if you can find those things, and then you try to treat. Like, I always start soft tissue first, and then reassess the range of motion, because that's the easiest, it's the safest, you're not torquing anything, and oftentimes that's enough, right? All of a sudden the pinch goes away because you've freed up some motion or whatever it may be. So I would do, you know, passive range, soft tissue, passive range again, see if you still pinch, then go to your joint accessory stuff if you have to. But the last thing I would do is just jam it up there. That's like saying, you know, like, well, you know, every time I hit my head against the wall, I get a headache. You know, maybe I should keep hitting my head against the wall to treat that. Is that a bad analogy?
No,
That's pretty good.
It was accurate. It was accurate. It was a bad analogy, but inaccurate.
That worked real well.
Yeah, I have a headache this morning and banged my head against the wall.
Also, error of mine as a younger therapist was not looking at thoracic spine with a general population older person. If they lay on their back and they're very kyphotic and you're trying to get there, sometimes you like work on T-spine, lay someone sideline, things change. So just throwing that out.
Yeah, figure out why they lost the motion.
Scap motion is for sure.
Don't just work to it. So we kind of get mad at the self mobility fitness crowd all the time that just jams it up there and grabs a band and jams it up there. We kind of get mad at that. But clinically, like with rehab specialists, we could do that too if we're being knuckleheads and just keep jamming it into the impinged tissue. You either didn't find the true cause of why they lost motion, or you jumped right to stretching, but free up the soft tissue, free up the capsule, that sort of stuff.
think sometimes we jump straight to soft tissue stuff because you see a lot of baseball players, so it's so common and it works really well. But I think looking, like Dave said, at the thoracic spine, looking also at the scapula, see what's going on with that. A lot of times you maybe work the upper back and the pinch goes away too. So work what you need and use your treatment sometimes as figuring out where the problem lies. So.
Right. Yeah, and use Dave's approach, kind of, work soft tissue, work thoracic, work scap, work all these things, but keep reassessing, and you'll figure out which one gives you the most bang for your buck.
Sure. Good job, y'all.
Awesome, y'all. Thanks, y'all.
That's it.
Scoobs, good work. Good job.
Scoobs crushed it.
Awesome. Thanks again, guys. We appreciate it. Go to MikeReinold.com, click on that podcast link, and keep asking away. It's some awesome questions. And do us a big favor, go to iTunes, rate and review this podcast, and we'll see you guys on the next episode.